taking time out of your Saturday to join us. I'm a urogynecologist. I'm a obstetrician gynecologist by training, and have been dealing with what we term sort of pelvic floor dysfunction my entire career, which I unfortunately have to tell you has been about 30 years. The problems we're going to talk about are extremely common, but unfortunately have been sort of what I would term in the closet problems, where women have been reluctant to talk about it. And that's led to a lot of confusion and misperceptions in the lay press around these various things. We're going to specifically talk mostly about bladder control and bladder issues, and really excited to introduce you to a new device that is truly cutting edge from a technologic standpoint. And we're very fortunate at Liftique to be the only commercial or medically based entity that has the access to this device in California at the present time. So let's start off by just talking about what pelvic floor health and dysfunction or abnormalities are. So this is a very, very simple drawing of the structures that occur in the female pelvis. When we talk about the female pelvis, in the upper part of the pelvis, we're talking about the bladder and the urethral tube, which is the little tube that you urinate out of. In the middle part of the pelvis, we're talking about the vaginal canal, of which the top of that is invaginated by your uterus or your womb. And in the lower part of it, the part that's sort of, if you're laying down closest to the floor, is the lower gastrointestinal tract, which is the opening of the anus and the lower portion of the rectum. So we're looking at all of this from a side view, and we've got this big purple sort of structure that's going across all three structures, and those are what we call the pelvic floor muscles. These muscles have been sort of denoted to be, not sarcastically stated, the smartest muscles in the female body. These are the muscles that tolerate the extreme stretching that occurs when a head comes through the vaginal canal during childbirth. These are the muscles that very eloquently control bladder and bowel function, which is a very, very complicated process. These are muscles that are very, very important in sexual satisfaction and having normal sexual function. So they're very, very smart muscles. Unfortunately, these are muscles that are somewhat deep in the pelvis. And what that creates is your inability to appropriately isolate and build that muscle. So if you take the analogy of wanting to build your biceps, you can easily do that because you just do curls with your arm and you know your biceps are going to get stronger. These are muscles that are very deep, and they're surrounded by other large muscles, such as your gluteal muscles and your abdominal muscles, that are more readily apparent to you. So bottom line is, women that think they're doing the quote unquote Kegel exercises, 80% of the time at minimum, you're not isolating these muscles. You're recruiting muscles that have no impact on your pelvic floor function. And that's something we've known for a while. And you're going to see that this new device gets rid of that blockade of your inability to isolate these muscles. So we're going to talk about better bladder control, that if you've got a problem with bladder leakage, it can be very simply non-surgically addressed and very commonly improved if not cured. So if you were to broadly classify the leakage that occurs in a otherwise healthy, neurologically intact female, we broadly classify it into two problems, or a combination of both of these problems. The first, as you see on your left, is what we call stress incontinence. It has nothing to do with emotional stress. Stress implies anything that causes a rise in your abdominal pressure. Anytime you cough, you run, you jump, and there's various degrees of this. In some women, say that are bodybuilders, or only when they extremely exert themselves, they may leak. Other women may leak every time they take a step, may have a little bit of a spurt of urine outside. Again, this is cough-induced, stress-induced, induced leakage that occurs from a rise in abdominal pressure. This is a problem with the little tube that goes from your bladder to the outside called the urethra. The other big type of leakage is the "when I gotta go, I gotta go." The commercials you see on TV for something called an overactive bladder. This is a problem with the bladder itself. The bladder is nothing more than a muscle, and it's supposed to be voluntary, meaning a woman should be able to sense when she feels she needs to go, should be able to comfortably get to the toilet, sit down, and urinate at her wishes. Now, unfortunately, for reasons we don't fully understand, that voluntary process becomes involuntary, and the bladder goes into a spasm on its own, and it just pushes urine out. So that's the "when I gotta go, I gotta go." Very, very common. Huge money-making industry for pharmaceutical companies and device companies on both of these types of leakage, and they coexist probably 30% of the time. Next
Dr.
slide.
Karram.
Yes.
Hi, this is Elaine Kopinga. Dr. Karram, question for you. What percentage of your patients would you say have stress incontinence versus urge incontinence, or a mix of both?
So it's a great question. In general, that is somewhat age-related. So younger women that are more in their childbearing ages and post-childbearing ages are going to be more stress incontinence versus overactive bladder and urge incontinence. I'd say maybe 70 to 30. And those numbers significantly shift to being more overactive bladder versus stress incontinence as a woman ages. Across the board, they coexist at least 30% of the time. It's important for you to understand that if you have this problem, you're not the Lone Ranger by any means. The problem here is an extremely prevalent problem, and unfortunately, our society and commercial entities have made most of you think that it's just a normal part of aging. Just like a woman has to buy a menstrual pad every month for a few days, this is just something that you got to deal with. And so don't try and correct it. Just understand, go out and buy the best poise pad or the most comfortable, best absorbable pad, and just realize that's the way you're going to have to live for the rest of your life. This is probably somewhere in the range of a $3 to $5 billion business in the United States. Next year, I'm being told that the adult protective wear, the adult diaper business, is going to exceed the baby diaper business, and 80% of those diapers are for women. So this is a problem that it can be dealt with and can be significantly improved or cured in a major number of patients. And then on top of that, you've got a variety of medications and surgical interventions that are mentioned on this slide that are, again, multi-billion-dollar businesses that unfortunately many times don't work real well, many times don't have longevity, and many times have untoward complications. So with that said, it certainly makes the most sense to try some minimally invasive, well vetted options that you certainly should exhaust before you move to these more aggressive interventions. So with that said, I'm really excited to introduce you to Jessica McKinney. Jessica McKinney, you're all familiar with physical therapists. These are the people that you go to when you have knee surgery or shoulder issues or back issues. There's also a very, very robust segment of physical therapy that has come to existence in the last 10 or 15 years called pelvic floor physical therapy. And these therapists are tremendously needed because of the issues I earlier discussed regarding your inability to isolate these muscles. So people like Jessica are your private trainers for improving your ability to isolate and contract these pelvic floor muscles. And these pelvic floor muscles are key in both types of incontinence that I showed you. In the stress incontinence, if you can build these up, you'll increase the resistance to the ability of a woman to leak urine out of her urethra. And if you increase your ability to isolate and contract these muscles in the overactive bladder group, you basically will many times abort the bladder spasm from happening because they have to work synergistically. So with that said, Jessica is going to talk to you a little bit about pelvic floor physical therapy and introduce you to some exciting technology that will allow you to improve your pelvic muscle strength and control in the confines of your own home. So Jessica, go ahead and take it over from here.
Great. Thank you so much for that introduction, Dr. Karram. So Dr. Karram gave us an introduction to the different primary types of urinary incontinence in women. Frequently in discussions amongst each other, or first discussions with healthcare providers, leakage is the term that women often use. And it's important to understand that people are often seeking the answer for why they are leaking in the first place, and that weakness or an incoordination of the pelvic floor muscles from the way that they are normally supposed to participate in supporting the bladder can be one of the primary factors that we can address when dealing with leakage. So when those muscles have lost strength, when they maybe have experienced a little bit of damage due to pregnancy or childbirth, or have just become uncoordinated and are not firing at the right time, all of those can be causes of leakage. So the pelvic floor, when we talk about it, sounds kind of singular. What you can see in the schematic that is here on the screen is it's actually a collection of muscles. They run from the back insides of your pubic bone in the very front, which you see on the left side of the circle, kind of in shadow form. And they go back and encircle all the way back to your rectum. And there are several muscles on the right side and the left side. And if you can imagine, putting your hands on your hips on either side and, you're resting on your hip bones, that your muscles, they are filling in that space. And so there is a depth to the muscles and a breadth to the muscles as they go from front to back and kind of fan out around the sides to provide support. And that these muscles, while they, we can give them all discrete names anatomically and dissect them out from right to left and talk about them with a lot of specificity. The point is that they actually all fire together. This is a group of many, many muscles that are supposed to work in a coordinated fashion to support multiple parts of health. So they are a part of supporting bowel health and sexual health, but certainly bladder health and continence. And so when these muscles activate, they can be trained voluntarily. So there's a lot that they're doing in the background that we aren't thinking about from the physical therapist point of view. We describe them as postural muscles. So there are muscles in your neck, for example, you might think of as postural muscles, and you don't have to think constantly about having them be on to help support your head on top of your shoulders and your neck. And so the pelvic floor is similar in that they are working together in the background all the time, but they also have the benefit of being able to be trained voluntarily the way that you would think of training any other muscle group in your body. And that's a really valuable thing when we start to have some areas of dysfunction and need to train them to be able to address problems with bladder control. Next slide. So here we've added a few different labels to the slide so you can start appreciating how that group of muscles is really providing support all around the bladder, the vagina, and the bowel to be able to support it. And when these muscles are exercised and trained, they produce a drawing in and a squeezing motion. So there's like a lifting and a squeezing motion when these muscles are contracting. So this exercise and strengthening of the muscles can be done to address your leakage. So if you're experiencing either types of leakage, there is something that's familiar to us in the healthcare space called a care pathway, which means if you have a health condition, what is the first thing that you do? What is the second? What is the third? And so how do things fall in sequence? And so the exercises that we think of as pelvic floor muscle exercises and pelvic floor muscle training are the first step on this pathway. And so all of these muscles that are tucked then inside of your body, we can exercise and strengthen them to reduce the risk of leakage. So this highlights what I mentioned earlier, that these exercises are highlighted by every professional organization that deals with this space. That is, every professional organization in the US and internationally say that it is really important for women who are experiencing urinary incontinence and other types of pelvic floor disorders to get supervised training and to learn how to exercise their pelvic floor muscles to rebuild the strength and coordination that will help to restore function. We call this first line treatment. But the piece remains that they are really challenging to do. The statistics show that, among women who have a pelvic floor disorder, so that includes urinary incontinence, but it can include other types of bowel control issues and others, only a quarter of women who have those issues are performing the exercises on their own without any type of assistance. That may be assistance from a physical therapist or from some type of training device or another healthcare provider to help them know what to do and get them on track. One way that I often talk about pelvic floor muscle exercises in plain English is that we've done all of the study that can say that they work. Right? Pelvic floor muscle training will work, but they only work if people do them, and they only work if people do them correctly. And so the doing them and doing them correctly often end up where the physical therapist and where other resources become available to women to help them on that path. So that's where the LEVA steps in as one of the tools and resources that is available to women who are wanting to be on a program of pelvic floor muscle training, but would really benefit from some additional support to provide the affirmation of I'm doing it correctly or I'm not, as well as tracking changes and progress in their exercise training over time. There are some things that are pretty unique to the LEVA as a device in the way that it reflects the motion when your muscles contract on the screen of a smartphone. So what we see here on the left side of the screen is the LEVA probe. It's the purple at the very bottom. That is a medical grade silicone, incredibly soft, flexible probe that's inserted vaginally. And it contains several movement sensors that create a composite image on the screen of the smartphone, which you see there above the device itself. So it's transmitting that information to the screen so that a woman is able to see how all of those movement sensors are resting when she's not doing anything, and then when she contracts her muscles, how they move in space. And if you think back to Dr. Karram's example before about training your biceps, if you would grab a weight in your hand, a dumbbell or a kettlebell or something in your hand, you would bend your elbow. So that is how you know you're using your biceps and moving through space. You're bending that elbow up. And so this is what we're looking at here. We're able to see when those pelvic floor muscles we saw in the previous slides are producing a lifting and squeezing motion, moving the probe through space. So it's a really unique way to look at it. I have been in this space of not only being a physical therapist, but in pelvic floor PT for 20 years this spring. And we've never had anything that is reflecting movement the way that this is. There have been a lot of other types of technologies applied to it, but the ability to capture that as a movement-based feedback is incredibly unique and a real contribution to our field. So here we see a close-up of it. So there are multiple motion sensors, 6 in total, that are enclosed within the LEVA probe. And we see this close-up image of the screen. So you see the divide on the smartphone image that's on the right-hand side of the screen. And what we're seeing here is a woman who is performing the contraction. So that line, the dark purple line, has moved to the left on the screen. That is in the positive and affirmative direction. when she starts, it's going to be resting close to that division of colors. So if she does it incorrectly by, say, bearing down, so that way that someone might strain to pick up something really heavy or to have a bowel movement, it's called a valsalva, and that is a really common way that people misperceive what they're supposed to be doing when they're trying to do a pelvic floor muscle contraction on their own. So what we have here as an advantage is if that is done, the purple line, the dark purple line, is seen moving in the negative direction, that a woman is able to then readjust. And that is a very clear signal. I've done it incorrectly. I need to make some adjustments and try again because I know which direction I need to be moving. These motion sensors, we have this in just to kind of get a sense of orientation. People often are like, well, what do you mean it's motion? They're these tiny, tiny little sensors called accelerometers, and all of us are walking around with them all the time. They are in our telephones, our smartphones, and they are what lets the phone know whether it has to orient to a portrait or a landscape view. So they are picking up on the force of gravity that is acting through that sensor. And as our phone moves, it switches the orientation. And that's what's used within LEVA to produce that image on the screen. As the motion is being produced by the pelvic floor muscles, gravity then acts differentially on each of those individual sensors. And we use that to calculate the motion of the pelvic floor muscle contraction. So this is a device, including app, that is FDA cleared and approved for all of the types of incontinence that we're talking about today, as well as for pelvic floor muscle strengthening in general. There is a timed pelvic floor muscle training coaching aspect to this, so it is embedded in the app, a recreation of the degree of lift, so that motion that's happening is reflected on the screen, and all of the data is stored and captured so that someone who is using this therapeutic is able to see how they are changing and making progress over time. This is a slide from some data from the very first study that was performed with the LEVA device. So I can just make a note that the scientific study of any device that is claiming to be therapeutic in nature is an important piece of making sure that something is is making all of the contributions that one hopes and claims that it will be making. And so the LEVA device has been studied in several different ways. And this slide and the next are talking about what we did in the very first study with LEVA. So there was a group of women who had urinary incontinence. It was primarily stress incontinence, so the type with physical activity and motion and body changes, but some women who had urgency incontinence as well. And we saw at the beginning that the survey that they filled out related to their quality of life was upwards of, we see here on the screen, it was just shy of 20, and that over a period of 6 weeks of doing these exercises twice a day, that number dropped significantly in the first 2 to 3 weeks. You don't have to be a scientist or anybody who's regularly looking at this type of data to see that line drop is quite substantial. And there were some mathematical applications applied to this for us to know that this was what's called statistically significant in terms of the change. This is a huge change in score and improvement in quality of life with just 6 weeks total of a training intervention. And I should say that the recommended training is 2.5 minutes twice daily. And so that's what everybody was doing in this study. It was 2.5 minutes of training twice a day. It was also that many women saw symptom improvement by the first week, and most of them, 87%, had no leakage by the end of 6 weeks. So this is a pretty quick change in terms of pelvic floor muscle training and symptom improvement in urinary incontinence to frame that, because I don't presume that anybody is maybe as well up on all of this literature, but it's typically recommended that people are on a program for about 12 weeks before they are expecting to see changes. So to see changes in this population beginning within the first week, substantial changes by week 3, and across the board changes for the group by week 6 is pretty significant. And if you think about trying to adopt a new exercise program, it's really helpful to see progress sooner. That's a real motivator for people. And so those were some pretty exciting findings. I say that the company has used this to be able to pursue some additional studies to continue to see how this is replicated in larger groups of women and in different areas. And I can say based on some unpublished data that very good results are forthcoming from that work as well.
Well, thank you so much, Jessica, for that presentation. My name is Elaine Kopinga. I'm a nurse practitioner and certified nurse midwife, and I have the opportunity to work with patients on the opposite end. So typically patients come and see me or see Dr. Karram first, and we're the ones that will end up referring our patients to physical therapy. And now that we have the Leva device, that's another option that we can recommend. Next slide, please. And so for us, I can definitely attest to what Jessica is saying, that with the majority of patients, and I'll be honest with you, I think for me, working with Leva, I've had only one patient that Dr. Karram and I have had together that has been using the Leva that did not have the results that she wanted. Other than that, all of the patients that I work with have been able to say after using the Leva, even for just 2 weeks, they notice a significant decrease in their incontinence.
Yeah, I'm sorry, Lynn. Just one other thing I just want to underscore as we get into some other areas. The company that makes the device is extremely efficient and
Yes.
will take care of everything in regards to getting you up and going and making sure the Bluetooth aspects are working.
Absolutely.
and working with you on everyday issues that may come up. I've never seen a company be this engaged on a one-to-one basis on individuals that elect to utilize the device.
Absolutely. And just to, again, underscore what Jessica was saying, we're so often in clinical practice, women will come to us and say, oh, I'm having some incontinence, I'm having some leakage. And Jessica's right. Every, specialty out there recommends doing these pelvic floor exercises. And what we've been trained to do is tell women, go do Kegels and come back and see me in 6 weeks. Well, when the majority of them come back to see you in 6 weeks, they say it didn't work. And now with the research, we're learning, well, the reason it's not working is not because women aren't trying, but because many women just don't know how to isolate those muscles. And so, one of the things we've been doing then is saying, okay, if it's not working, go and see a physical therapist. And now together, in conjunction with physical therapy, we can also recommend the Leva device so that they can work on this at home for 2.5 minutes in the morning, 2.5 minutes in the afternoon, and have significant results. And for me, working with patients that use Leva and then working with patients that don't have access to Leva, it's a big difference. It's a big difference. So it's definitely a game changer and something that we're very excited about. For me, as a nurse practitioner and midwife, one of the things that I work with my patients on so often is sexual wellness. I have, women that come to see me both that are childbearing age, so in their 20s and 30s and 40s, and then I have postmenopausal women coming to me and saying, things have changed. I used to be really excited to have sex. I used to be, my partner was excited, but things have changed for me, and it's making me not want to have sex. And so you see the slide here where the man is looking for 101 positions to have sex, and the woman is saying, how can I get out of this? And so these are women that have finally realized they don't have to be unhappy having sex, and they're searching out and looking for reasons why it's happening and things that they can do to fix it. 50% of women that are what we call perimenopausal, which is the period that is right before menopause and when you're going through menopause, and postmenopausal, will complain about experiencing vaginal dryness by the age of 55. So that is 1 in 2. Half of women are complaining about this. And for me, it's not just women that are postmenopausal or perimenopausal. I also have women that are postpartum that are coming to me and saying, I've had a baby, things have changed, it feels different, and sex is not as enjoyable, or it's just painful. And so one of the things that I want to really stress today is that if you're experiencing these symptoms, raise your hand and say something. Come and see us, and let's talk about what you're experiencing and how we can help you. Because if you're experiencing vaginal dryness and painful intercourse, or just pain in general, some women will complain about feeling dry and itchy. They'll say that their vagina feels like feels like there's sandpaper. It feels like broken glass. Don't ignore it, because these symptoms will not just go away on their own. And so today we're going to talk very quickly just about ways that we can help you to reduce these symptoms of vaginal dryness. There's a slide here that has what I call a quote unquote a normal vagina, so vagina that is not affected by vaginal dryness, which is caused predominantly by a decrease in estrogen. So women that are perimenopausal, postmenopausal, their ovarian function is decreasing. They're no longer having periods, so their body is no longer putting out estrogen at the same level that it did when they were in their childbearing years. For women that are postmenopausal, they're breastfeeding, so their body will just naturally decrease the estrogen output, and they will have the same symptoms that someone is having if they're postmenopausal or perimenopausal. So you see on the left-hand side a vagina that is functioning at, normal estrogen output. You can see that it's wide, it has ridges, and when we do an exam, we see that it's pink, it's lubricated, it's smooth. And if we see on the right-hand side here, we'll see a vagina that is affected by that decreased estrogen output. And the term that we use for it is atrophic vagina or vaginitis, which is inflammation. So you can see how the vagina is now more narrow. It's lost that what we call the rugae. It's lost that the ridges. And that is a big contributor for women having painful intercourse. So now upon penetration, the penis or anything that's penetrating a finger, a device that's penetrating the vagina has a more narrow opening. It has a decreased lubrication, so it feels tighter and more painful for the woman. And what happens is when it's more painful for the woman, her partner then gets panicked and says, okay, well, this hurts you. I don't want to do this. And so it becomes this vicious cycle of where the woman doesn't want to have sex for physical reasons, but emotionally she still desires affection, and the partner saying, I don't want to do this because it's hurting you. And so both people find themselves feeling more isolated. Next slide, please.
Elaine, before you leave that, Russell, go
Yeah.
back to that just for a second, that slide. Just one other thing, Elaine, on this is the other thing that people underestimate is the whole environment of the vagina changes as you lose that estrogen. Basically, the vagina should be acidic during your premenopausal years, and you lose that acidity again when you lose the things that Elaine alluded to. And what that does significantly in women as well is increase your likelihood of having a urinary tract infection.
Yes.
So one of the things that also occurs as the vagina becomes atrophic is that environment changes, and you're at much higher risk to have organisms that normally live in the vagina go up into your bladder, into your urethra and your bladder. And then the other thing that comes along with the pelvic floor discussion, as these vaginas become more sensitive and thinner and drier, these, again, very smart pelvic floor muscles, they become tight and they become difficult because they're trying to protect the vagina. They're smart. And the reason they're protecting the vagina is because the skin is very, very sensitive. So that'll kind of lead us into some of the things that Elaine's going to talk about with treatment.
Absolutely. So I just got a question from someone. It was a great question. It actually leads into this slide. Someone asked, if you're taking hormone replacement therapy, will this protect you from these changes? The answer is yes and no. So if you're taking hormones and you're taking what we call systemic, so you're taking a pill to help you, it will help you deal with things like hot flashes, fatigue, lack of sleep, but it's not going to help you directly in the vagina. In order to really help these changes from occurring in the vagina, you have to use what's called localized estrogen, and you have to put it directly in the vagina. And the problem with that is if you're someone that has a uterus, then you are at increased risk for what we call hyperplasia, which is then a risk for uterine cancer. So yes, you can use estrogen directly in the vagina, and it will help relieve some of these symptoms. But now we have to monitor you constantly to make sure that you're not putting yourself at risk for uterine cancer, which sometimes which can mean adding another hormone. And for many women, they just don't want to spend their life taking hormones. They don't want to pay the money. They don't want to take it, not only with the risk of uterine cancer, it can have other risk for blood clots, stroke. So for many women, they don't want to be on these medications. And for some women, they can't take them. If you're a woman that's had breast cancer or other diseases, you're automatically eliminated from taking hormones. So the slide here talks about what do we have traditionally to help treat this. Over-the-counter lubrication, which can work up until a certain point, hormones, or the estrogen cream, which I just said carries its own risk of side effects. Or for many women, they can't even take them because of their previous health history. So I hope I answered that question. So again, this is a slide here that we have that says, I'm a victim of identity theft. Menopause took a happy, slim, sexual woman and turned her into me, which we at Liftique here believe that does not need to be the case. We have multiple options that can help you through postpartum and through menopause as your body's going through changes. So again, I think we've done a great job today of talking about what are the realities of menopause. Changes in your bladder, which can lead to incontinence or an urge to go to the bathroom, vaginal dryness, burning, and pain with intercourse. And just to, again, go back to what Dr. Karram talked about, not only does the change in the pH of the vagina lead to increased urinary tract infections, it also can lead to increased vaginal infections. So yeast infections, bacterial infections, again, it becomes this vicious cycle of dryness, infection, medication. And the medications can then lead to more infections. So it's just the cycle that goes on and on with the changes. So one of the things that we have to help treat the vaginal dryness is a CO2 laser called the Mona Lisa Touch. And it's a laser that we use in the vagina. We do it in the office. There's no medication required. It's virtually pain-free. It takes about 5 minutes for the procedure to be done. And what the laser does is that on a microscopic and cellular level, it actually changes the makeup of the cells. So if you look on the left-hand side here, this is a sample of a biopsy from the vagina, where we took a tissue sample from a woman who was having atrophic symptoms. And you can see here the cells are small, they're shriveled. After doing the Mona Lisa Touch, one treatment for 1 month, the cells look like the cells of a woman who could be 30 years old. The cells are plump, they're full, and this is what contributes to the vagina feeling like it did before you went through menopause. It's lubricated, it's fluffy, it's not narrow, the opening is larger, and this is what will happen after as minimum as 3 treatments with the Mona Lisa Touch laser. Dr. Karram, is there anything you'd like to add to this?
Yeah, just a couple more things. So I was fortunate enough to be the first investigator to study this technology in 2014. This technology comes out of Italy. And so we've got now, close to 6 years of experience. It truly is remarkable how simple this is and how efficacious it is. It basically does everything that local estrogen could do in the best of circumstances. So as Elaine alluded, it's an initial series of treatments of 3 to 5 treatments. Probably each treatment is about 4 to 6 weeks apart. And then that should provide a relief of symptoms and the changes that you're seeing for about a year. And then on an annual basis, you'll need just one touch-up treatment. We've now followed patients out for 4 years, and that seems to be consistent in that we're seeing this in perpetuity, that one touch-up treatment seems to then maintain the efficacy. But this truly is, and I don't say this lightly, game-changing, because again, as Elaine alluded, you've got a lot of women, breast cancer patients. We have 250,000 breast cancer patients diagnosed with breast cancer every year. These are patients who 80% of them are not allowed to take estrogen, and the other 20% won't, even if their doctor tells them that they can, because they're so concerned about a recurrence of their breast cancer. And that is basically, up till now, we've had no way to treat these patients. It's like, suck it up and live with it. So,
Exactly.
so yeah, go ahead.
No, that's exactly, Dr. Karram is correct. One of the things about this laser, and people often ask, well, when will we see results, or when will we see a difference? 50% of women will see a change after one treatment, and then some women will see a change after the second, third, and there's a few sampling of women that need maybe a fourth or fifth treatment, but I can say in my clinical experience, the majority of my patients after 3 treatments, the conversations during our sessions go from, I can't have sex, I haven't had sex in several years, to let's talk about different positions that we can do. Let's talk about different things that I can do to kind of boost my sex life, because I can finally have pain-free sex again. So it's a very rewarding field to be in, because I get to work with women who have been feeling isolated and scared, to women that are now excited about experiencing intimacy again and being able to enjoy it.
Yeah, there's a couple other questions I'll quickly take from Michelle K. Does your hormone replacement improve the environment as well? Yes, if you in a compliant way utilize localized estrogen cream, you'll get a change and you'll be able to maintain that acidity. But again, it needs to be in perpetuity. In contrast to systemic estrogens for like hot flashes and things, many times we can give you systemic estrogen pills or a patch or a cream for a short period of time, and then the hot flash, you stop the medicine, the estrogen, and the hot flashes go away and don't come back. It's been well studied. The cream, you have to use it continuously. As I said, in perpetuity. If you stop it, then all the issues with what we're talking about with atrophy come back. There's another question on bioidenticals. The problem with bioidenticals is they're not regulated. Exactly. And so you never kind of know what you're getting. And at least commercially available estrogen is regulated. So I'm not a huge fan of bioidenticals, just for that reason. And I've seen a lot of patients who have taken bioidentical creams and bioidentical pills and pellets and things, and they don't see the results. So I'm not a huge fan. Finally, there's a question on whether the Mona Lisa is covered by insurance. Unfortunately, it is not, and that's just our healthcare system. It's new. It's in the process of getting all the important indications that would be required to be covered. But the way our healthcare system works, it's going to unfortunately be some time before that, I think, actually occurs.
Again, so there's multiple different energy sources that we can use to treat many of the issues that we talked about today. So the Mona Lisa Touch is a CO2 laser. And again, without getting too technical and boring everyone, there's another energy source called radio frequency, which is a heat source that we are able to use to help women that are experiencing incontinence as well. So whereas the Mona Lisa Touch is great for women that are experiencing that vaginal dryness, and as a result of that vaginal dryness, they're having the incontinence and the issues with the UTIs, that's a great option. For patients that come to us that are dealing strictly with leakage and incontinence and urgency issues, the radio frequency is a wonderful option. It's also a great option for women that have had children and are feeling a sense. Many women will come in and say, after I've had kids, it just feels a little bit more loose. When I'm intimate, I don't have the same sensation, or my partner doesn't have the same sensation. Radio frequency is a great tool to use to help that pelvic floor feel tighter and help the vaginal canal feel tighter. It is also a very fast treatment. It takes about 10 to 15 minutes. It is completely pain-free. And it's quick. We do 3 sessions, also about anywhere from 2 to 4 weeks apart. And then we also recommend that patients come in once a year for a touch-up. Would you like
One
to add
other
anything?
thing in relation to that, and again, I don't want to ever speak negatively about other healthcare providers, but the reason we are utilizing, for example, the Mona Lisa Touch is because it's been scientifically validated. It's gone through over 60 peer-reviewed publications, and it's a specific treatment for vaginal dryness and vaginal atrophy. On the other hand, radiofrequency devices are utilized for the things that Elena just alluded to. Unfortunately, many physicians promote whatever device they've purchased for everything under the sun. And if you're contemplating having something done like that, feel free to reach out to us for a free consultation, and we'll be happy to provide you our thoughts on this. You have to really identify the appropriate energy source and the appropriate mechanism of delivering that energy source for your specific problem. This is not a one treatment, energy source intervention treats all different types of things. So just beware, because many physicians, plastic surgeons, dermatologists, even primary care docs, as well as GYNs and urologists, have invested in these various machines. And there's 25 different types of companies that pursue these, that sell these machines. So just, again, just a red flag to that point if you're approached about something like that.
And so, again, here at Liftique Blush, we offer multiple different treatments to address many different issues. So if you're a woman and you have a vagina, chances are at some point in your life, you either have or will deal with issues of urinary leakage, vaginal dryness, urgency, or even a cosmetic gynecology. Like I talked a little bit about women who feel that their vagina feels different after having children or after having gone through menopause. There's many women who feel like their vaginas look different. And while the truth of the matter is our partners may not care, if we care and it's making us feel insecure, then there are non-surgical ways that we can help the appearance of the vagina. The radio frequency is one of those ways that we can help with the appearance of the labia. Many women feel that it's maybe stretched out or it just looks differently. Then there's non-surgical interventions that we can utilize to help with that. And there's also surgical interventions if that's something that's needed. Then either myself or Dr. Karram can again offer you a complimentary consult and help to point you in the right direction. So we look forward to meeting you all in person as soon as we get the green light from the government to go back to the office. We're very excited to speak with you in person. But in the meantime, if you have questions one-on-one and you'd like to schedule either a phone call or a televisit like we're doing here with myself, then please feel free to call the office and schedule some time for me to speak with you one-on-one.